is about the integration of artificial intelligence in minimally invasive liver surgery with focus on right hepatectomy. In the early of the 1990s, minimally invasive liver surgery was introduced, demonstrating its feasibility and safety through various case series of laparoscopic minor and major hepatectomies. By the 2000s, laparoscopic donor hepatectomy was also introduced, and its indication expanded to include right donor hepatectomy. And recently, several expert centers have achieved a complete transition from open hepatectomy to a minimally invasive approach. However, globally, open hepatectomy still remains the majority, and the minimally invasive approach has not been widely adopted. In particular, pure laparoscopic donor hepatectomy is performed in geographically limited areas. This limited adoption is mainly due to the type of donation, which varies according to the cultural backgrounds. However, there are also various educational factors at play. And we found the possible solutions to this problem through the use of AI. These videos are excellent examples of how AI can assist during surgery with navigation and decision support interoperatively. As we are expert center of minimally invasive donor surgery, we try to adopt prior methodologies using AI to pure laparoscopic donor hepatectomy. So this is one example of AI in donor hepatectomy. When we try to transect the liver, it is important to know the border of right and left. The location of common hepatic duct bifurcation is good landmark for the right and left demarcation on the inferior surface. So this AI model predicts the location of probable bile duct bifurcation site, which can support surgeon's decision. And this is another application of AI, which visualizes biliary structure during surgery. And this model predicts the biliary structure with green color and suggests the transection site with blue color. Nowadays, standard procedure for identifying biliary structure is intraoperative cholangiography or ICG method. But this kind of AI and computer vision technology may replace current procedures. So this is today's talk's main focus, which is right liver mobilization process. This step is essential for right hepatectomy and may seem straightforward. However, it requires meticulous dissection to avoid the major vascular injuries. This video shows the importance of careful technique and supervision in this procedure. So our primary objective is to develop a navigation system for safe right liver mobilization using AI and computer vision. We designed a retrospective multi-center study involving 3 participating centers, 5 surgeons, and collected 48 pure laparoscopic donor hepatectomy videos. Firstly, we train and validate the model's performance with 40 videos from Samsung Medical Center and 5-fold cross-validation. And after this internal validation, we tested the model's performance on external data, 8 videos from Myeongji Hospital and Yeongnam University Medical Centers. For video pre-processing, we extracted the frames at 10-second intervals, resulting in a total of 2,700 frames. And to train the computer to understand the key anatomical structures, we performed pixel-level segmentation of vascular structures, including IVC and diaphragm vein, and avascular plane for the safe dissection. This is the deep learning model architecture we used. And to evaluate the model's performance quantitatively, we used dice similarity coefficient. The DSC measures the overlap between the ground truth and the AI prediction. As this value approaches to 1, the model's performance is good. This slide shows you the model's performance from anterior coronary ligament dissection. The model predicts diaphragm vein and suprahepatic IVC here and avascular planes very well. And during posterior coronary ligament dissection, which is inferior surface of the liver, the model predicts infrahepatic IVC and avascular plane here. And during triangular ligament dissection, the diaphragm veins are well visualized, and retrohepatic IVC also well visualized when the bare area is exposed. In terms of TSC, the model's average performance for the avascular plane was 0.68 and 0.7 for the vascular structures for the internal validation. And for the external validation, TSC for avascular plane was 0.66 and 0.7 for the vascular structures. Okay, this is the video clip. The area with green is avascular plane, which means you can go and dissect this area with coagulator. And the area with blue is vascular structures, so you have to be careful to avoid vascular injuries. So during triangular ligament dissection, you can see here avascular plane guidance, and diaphragm veins are also well visualized. And when the right liver is fully mobilized, you can find the retrohepatic IVC here, and this area is also well visualized, and avascular plane is also seen here. Okay, this study was experimental retrospective multi-center study and proved its feasibility upon internal data with acceptable dice similarity coefficient scores, and it also showed comparable dice score on external data set, which proved its robustness and generalizability. However, this study has limitations as the nature of retrospectiveness and lacks clinical application, so further steps should be taken to prove its clinical utility in the operating theater. In conclusion, AI and deep learning-based navigation for safe liver mobilization is a feasible approach with accurate and robust performance. Lastly, this is very multidisciplinary work of surgical professionals and engineers, so I'd like to thank to all contributors of this study. And thank you for your attention.
Thank you, Dr. Wong, for your nice presentation. This topic, so for discussion as Dr. Lee, please.
Yeah, Dr. Lee is so listener. It's a wonderful trial, but still we need to study more. I have a couple of questions. The first one is, what is the source of training? So just intraoperative video only, or did you consider CT or preoperative CT and MRI? And the second one is, what is the key landmark? I learned that from your video, diaphragmatic vein is one of the key landmark. But is there any some key landmark when you consider this project?
Okay, thank you for your question. And the first answer is we use only intraoperative videos only because of technical issues. And the second one is we train the diaphragm vein and IVC and short hepatic vein and other vascular structures when we encounter during right liver mobilization process.
Just which means just morphological features and AI can detect. There might be, now is the time to meet IVC, but it's time to meet right about vein insertion, something like that.
Yes.
The morphological training. Okay, thank you.
Any questions? During the preparation, I wrote one question, a simple question is, you collected videotape or 48 videotape from the 3 hospitals and the 5 surgeons that participated in this system, this development. So Depending on the surgeon's skill and the sometimes how many cases they made this kind of pure laparoscopic surgery who participate in your program?
Three surgeons from our center. They are kind of expert. And the two surgeons who are in Myeongji Hospital and Yeongnam University, they had cases of about 10 or more cases of PLDH.
Yeah, that means much more skillful surgeon do not need to this kind of AI system guiding, and but two hospital surgeons is helpful for this kind of AI guiding system. You adapted your program to the educated young surgeon. Did you do your program?
Yes, actually, this kind of navigation system is not necessary to the expert. So this kind of navigation system can be benefit to the young surgeons who do not meet their learning curve yet.
Yeah, but this is only right liver mobilization you adapted this program, but the main point is intraparenchymal dissection is more helpful for the young surgeon to adapt this kind of AI assisted program. Do you have any plan to expand it and deeply investigate about intraparenchymal dissection with AI assisted?
Yes, we do.
Okay. And yes, please.
Thank you for the nice video and the presentation. I'm Jae-young Kwon from Hallyu University. I wonder how long does it take to make the ground truth data for the old video, the frame,
Yes.
and how many surgeons participate that make the annotation for?
Yes. Thank you for your question. And actually, 6 surgical professionals participate in this annotation process. So it takes about more than 3 months. And 3 surgical assistants, they made a primary annotation. And then 3 surgeons have performed quality check. And then after that, we made a consensus from all 3 surgeons.
Thank you. Could you share the annotation tool used
Ah.
in the?
So annotation tool is just open source. You can find the CVAT. Yes.
Thank you.
Any more questions? Yes, please.
Thank you for this outstanding report. And a small question from Logan of Moscow Scientific Center, small radiological question. Why don't your collective did not use CT, constant Hansen CT with volume rendering on 3D reconstructions, because it can provide very high quality information about anatomical, about deepness and different other some variants and so on. Or it can be your perspective.
I deeply agree with your idea, but now so far the technology, the registration, the 3D image from the CT or MRI to the surgical video is technically difficult.
But in future we could compare and combine these images in by a computer vision and CT or MRI. Is it possible?
Yes.
Thank you.
Yes, thank you very much, Dr. Wo, for your nice discussion. And next, I would like to move to last